Hello everyone, Max here again. As an update, I'm more than halfway through my third year of medical school, and I'm very interested in emergency medicine. Today, we're going to talk all about atrial enlargement. So as a review, the P wave demonstrates atrial depolarization and dictates a rhythm that is sinus in origin. A few new ideas includes what specific pathways get us to the AV node from the SA node. There are 3 internodal pathways within the right atrium, and one that keeps the left atrium up to speed, called Bachmann's bundle, as you can see displayed here. So what can P waves look like? As we know, an upright, round P wave preceding every QRS complex in the inferior leads, especially lead 2, is an indicative of a sinus rhythm. Do you remember why lead 2 is a great lead to examine P wave morphology? This is because it follows the natural path of depolarization. The other lead that is important in assessing P wave morphology is V1. V1 is sitting on the right side of the chest wall in line between the SA and AV nodes. A normal P wave morphology can be equally biphasic, upright, or negative depending on adequate lead placement. The Venn diagram on the slide demonstrates our different types of arrhythmia that have a sinus origin from the visual nurse. In the chart, we can see cases of normal P wave morphology, right atrial enlargement, and left atrial enlargement. The rest of this video, we are going to discuss each of these cases and a rare complication that may occur as a result of one of these pathologies. Our first case deals with left atrial enlargement. Before we get into the nitty-gritty criteria, let's think about the left atrium. The left atrium receives oxygenated blood from the 4 pulmonary veins and empties into the left ventricle through the mitral or bicuspid valve. A quick way to remember which valve is which is you try before you buy. Left atrial enlargement is categorized by a broad double mountain shape in lead 2, termed bifid, a false peak for you hiking aficionados. This is in conjunction with the findings of a terminal P wave longer than 40 milliseconds and deeper than 1 millimeter in V1, and this confirms the EKG finding of P mitral. Well, as always, we have to ask, why is this important? Isolated left atrial enlargement, whether it is seen on EKG findings or an echocardiogram, is usually caused by mitral stenosis. Mitral stenosis is a diastolic murmur that is classically associated with an opening snap followed by a rumble, as opposed to the click heard in MVP. If left atrial enlargement is occurring simultaneously with LVH, the causes are typically disease states that result in increased afterload, or simply, the force required for forward movement of flow. These things include hypertension, aortic stenosis, or hypertrophic cardiomyopathy. Pop quiz time. Sorry I had to do it. This is a 44-year-old male with no past medical history, presenting to the ED with persistent cough and worsening dyspnea over the last 3 months. He hasn't had any fevers, chills, or sputum production. Over the past year, he's had progressively worsening shortness of breath and P&D. He has not had chest pain, but he does have palpitations. He's not used tobacco or alcohol, and he has moved from Southeast Asia to the U.S. 10 years ago. On exam, he's in mild distress, with unremarkable vital signs apart from an irregular tachycardia. Lung exam reveals crackles, and chest X-ray showed an enlarged cardiac silhouette with vascular congestion. Notably, the left mainstem bronchus seems to be elevated, and there's no other lung pathology. The EKG shows atrial fibrillation. So what's the most likely cause of this patient's presentation? Right off the bat, he's showing signs of decompensated heart failure. He also has signs that there is compression of extracardiac structures, like with his persistent cough and displacement of the left mainstem bronchus on the chest X-ray. And how about his new onset AFib? Do we remember why elevated left atrial pressures can lead to this arrhythmia? Think about its association with obstructive sleep apnea. Left atrial irritation can cause AFib to originate in the area surrounding the pulmonary ostia, as we discussed in previous videos. Ultimately, this patient has mitral stenosis secondary to rheumatic heart disease, with signs of left atrial enlargement. It's also important to remember that new onset AFib can be due to thyroid dysfunction, so don't forget about this association as well. Next up, we have right atrial enlargement. As with the left, there are criteria that dictate what fits right atrial enlargement. A very large peaked P wave in the inferior leads is very telling of this. This pattern is termed P pulmonale. If we think about right heart, its forward flow is to the pulmonary artery into the lungs, while it receives blood from the systemic venous circulation. So what causes right atrial enlargement? Things that affect right heart. Chronic lung disease like COPD, emphysema can cause cor pulmonale, which can lead to P pulmonale. Others include tricuspid stenosis and other congenital heart defects that disrupt pulmonary outflow, like tetralogy or pulmonary stenosis. Cor pulmonale is diagnosed in the absence of congestive heart failure. As you can see in the EKG example, the P wave amplitude is very large in the inferior leads. These waves are greater than 2.5 millimeters in height in the inferior side, and deeply negative in V1, greater than 1.5 millimeters. As a side note, the QT interval looks a little suspect as well. Think about some causes of QT prolongation and the arrhythmia that can ensue from this. Let's switch gears for our final topic of the video and discuss the basics of flow in the central cardiovascular system, right heart and left heart basics. So as we know, right heart receives from the venous system and pushes into the pulmonary system. Left heart receives from the pulmonary system and pushes systemically. And as we remember our anatomy, the left atrium is more posterior in the mediastinum, while the RV is more anterior. Think of the intercostal penetrating trauma. Well, let's say our patient has severe mitral stenosis, and we described how this would sound on auscultation. And what other structures are in the area? Think of maybe one particular structure that wraps around the aortic arch on the left side and its counterpart around the subclavian artery on the right. Give you one more hint. Here's an artist's representation of the laryngeal anatomy. As we can see, the left recurrent laryngeal nerve wraps around the aortic arch as it continues as the vagus to do a lovely job keeping us in parasympathetic homeostasis. If our left atrium is enlarged, we can impinge this nerve, which has very specific consequences that can be heard. Alright, enough teasers. This is Ortner syndrome, or impingement of the left recurrent laryngeal nerve, which can cause vocal cord dysfunction and hoarseness. It can occur in left atrial enlargement, neoplasm, or, in this case study I provided, in a rather large pulmonary aneurysm in the setting of chronic thromboembolic pulmonary hypertension, or CTEPH, which is definitely worth reviewing. That's all I have for this video. I hope you found it enjoyable and learned at least a few things to carry forward. Thank you for listening, and I'll see you next time.